They're having a brain attack. And we can't say to them, we don't have a bed today, and why don't you come back in 2 weeks? Or worse yet, go to the mental health center. Now, I love my mental health center, but they may not have an appointment in 2 weeks. They may not have an appointment in 3 months. Or you'll be seen in 2 weeks by someone with a social work degree, and God knows I love my social workers because they're fantastic. But they can't write a prescription. And if you can't see a doc for 4 months, well, you're not being very well served. So I've talked about systems of care. I've also talked about or alluded to stigma reduction. A heart attack, your pancreas isn't working, your liver isn't working, your brain isn't working. Those are all attacks, and they need to be treated acutely and appropriately. I also mentioned earlier when I introduced Pete Lane that substance abuse and co-occurring disorders should be an expectation, and we can't just build in care here in mental health. We have to make sure that people understand that substance abuse is a mental health issue. Certainly several of our speakers, and I predict anybody who's participated in the mental health system, understands that one of the major problems is access. And I love our emergency room at UAB, but if you have to wait there for 12 hours to be seen and a decision is made for you to be admitted and you have to wait for another 72 hours because a bed isn't open, that's not good. We need to think about stepping in before somebody needs to come to the ER, or if somebody needs services, how can we better provide those services in a more therapeutic fashion? I would be remiss if I didn't talk about workforce development. There's one of me. How many other physicians are in the audience? One. She's my resident. And she is splendid, and she went to the NAMI conference last year, and she is on the NAMI board in Birmingham. But I think that says something to me as a physician and psychiatrist that you have 2 psychiatrists here. We need to have more psychiatrists, not necessarily to lead, but to participate. I need to be able to recruit medical students and residents into training in public psychiatry. 50% of psychiatrists in the United States see people on a cash-only basis. Well, a lot of my patients don't have much money. And so we have to come up with some form or fashion so we can recruit people who want to join this cadre of professionals, who want to provide, who want to work with people in community and public psychiatry, who need to understand that this is the most joyful career that anyone could have. Mark reminded me when I saw him last night, he goes, you know, Dr. Feldman, you were one of the first psychiatrists I ever saw. And then I remembered who he was. He looks very different today, and I'm happy for him for it. But it's like, oh, wait, there's not enough. There's not enough of us. So we need to figure out some way to entice, engage people to come into psychiatry, and or nurse practitioners and or PAs. You know, I don't care what credential you have behind your name, but we need people who come in and want to work. The very first patient I saw, lovely patient, his first question was, who you for? And he was wearing an Alabama t-shirt. I came from Duke. All I cared about was basketball. And I said, Tommy, I'm for Alabama. And he literally picked me up and swung me around and said, we're going to get along great. His second question was, how long you here for? Because his experience was he had changed doctor after doctor after doctor. And I knew I was blessed. And I said, Tommy, I'm here until I retire. And indeed, Tommy was virtually the last patient I saw when I stepped out of the community psychiatry program. And that's important. Relationships are important. Engagement is important. Welcoming people and say, I am so happy to see you here today is important. So we need to grab onto that theme. Education, our last speaker just spoke about, is so important, and she underscored several of the NAMI programs that are phenomenal to getting you engaged and thinking about what it's like to have a mental illness and how you can best help those who are living with it. The last thing that I think is really important and why it's so important that we have this panel here today is the importance of learning from consumers and family members. If you haven't experienced it, it's easy to feel clinical about it and go, yeah, I understand. But unless you hear someone who's lived with it and understand the challenges, as well as the high spots, as well as everything in between, you can't really begin to understand. So I applaud you all sitting up here and talking with us, and hope you can continue to guide us with your leadership. Thank you.
Thank you. I will be quick. I'd prefer to hear your questions, and nobody's ever said, I wish he had spoken longer on something. I've never heard anybody ever say that. I will sort of speed through what I wanted to say. I'm Judge Stephen Wallace. We reinitiated a mental health court here in Jefferson County. For the first 3 or 4 years of what I did, I'm a criminal judge. I sentenced people. And basically I had and tried people and did all the things you see on Law and Order. That's fun, that's interesting, but when it came to sentencing, I really only had a few options. That was to send somebody to prison, that was to send somebody, put them on probation, and then we have something here called community corrections also that task runs here in Jefferson County. And for the most part, those were my options. I will let you in on something. People run into me, family members, they go, oh, this job, it must be so tough. It's really probably the easiest job I've ever had, to be honest with you. As far, I had one summer, I had to change oil and move tires. And that was hard. The easiest thing a judge can do is sentence somebody to prison. The harder thing is to see what alternative may lie out there that may function and may serve them better to avoid incarceration. That's far harder to do. It's much easier to send somebody to prison. So we restarted mental health court, and I sort of changed. I continue my role of trying cases, hearing cases, deciding things. But I've really taken on this role of mental health court, which is separate. I really see it as social work in a lot of ways, and that's not what I was doing before. And again, let me separate. This isn't civil commitments. These are people charged with criminal offenses that we're dealing with. And so we restarted it, and we wanted to look at what are we trying to accomplish? Are we doing this just to make ourselves feel good? What is it we're trying to do? And one of the first things we were trying to do is cut down on incarceration and cut down on holding people and warehousing people in the county jail. I assure you that the county jail is no place for people with mental illness. I've never seen somebody really improve from that. And in fact, the jail doesn't want to hold these people either. I've learned that too. And so we tried to cut down on that. We have certainly tried to direct people away from the criminal justice system, get them connected to treatment, get them connected to services, and hopefully by coming through the system they are better off for being there. Those are just some of the things. And the other thing I stress too is public safety. We have a number of people, as you well know, that are on our streets right now, unmedicated, without treatment, without services, indigent, and that is a public safety component. And I'm so happy to see so many people from law enforcement because they have to encounter these people in very difficult situations. And so thank you for being here. And so that's sort of what we're trying to accomplish. We started a mental health court. It's like a number of therapeutic courts you're probably familiar with. Drug court, we have veterans court, we have mental health court. I think there's one in Tuscaloosa. There may be one in Madison County, maybe one in Shelby County. And so what we try to do is when someone is taken into custody, identify them early on. We have an instrument in the jail that identifies if they are suffering from mental illness. We get them attached to a caseworker. We let their lawyer know that this person may be suffering from a mental illness. And we see if they are a good fit for our program. One, they have to be interested in it. It's a voluntary program. We don't force people to do it. They have to have a qualifying diagnosis. And it has to be an offense that's appropriate, that the DA and the victim. And that's something else I want to stress, is that a lot of times we have brought the victim and the person charged together, and there's a meeting of the minds that there was something going on in this person's life that's serious, and you see a lot of compassion from people, certainly victims, when they realize that they just want somebody to receive help. And the other component is generally there needs to be some relationship between the criminal conduct and the offense, or between the mental illness and the criminal conduct. So we connect them to a caseworker if they're admitted in. We hopefully help them with housing if they need that, help them get an ID, connect them to treatment, services, whether it be mental illness, whether it be drug treatment, and we monitor them for a certain amount of time. And if they do well, the carrot is that we often are able to, in many instances, dismiss their cases. Maybe their charge is reduced. And so there's something at the end, and there's also some fulfillment that they have accomplished something, they got something for it, and hopefully we have put them on a better plane where they don't encounter the police again under these often stressful circumstances. And so I'm proud of what we do. It's been really eye-opening to me. It's been real eye-opening to hear a number of these stories. I will tell you that when we first started the program in terms of cutting down on days of incarceration, there were a number of people that had been held in our jail for a year or two. They were charged. They were going through the process. But there was simply no one to connect them to services. And I'll let you in on a secret. Judges are risk averse. And if given the choice between worrying that somebody might hurt somebody and keeping them in jail, they will generally go with the jail. And so you've got to give judges an opportunity to see what alternatives there may be. And fortunately, when we got started, we were able to cut down the number of jail because it's far cheaper, those that are with county government, it's far cheaper to assign them to a caseworker than it is to incarcerate them. I mean, it's just off the scale. So that was one of the early things I encountered. The other thing I encountered was just the stigma attached. We had a number of people that would have rather admitted that they were suffering from alcohol abuse than suffering from a mental illness. You know, that never occurred to me, and I thought that was interesting. And so we're trying to destigmatize that. And then one of the latest things I've tried to deal with is we have a lot of trauma victims that come into our court and are suffering from that. And so while I look like a nice guy, I hope so, I definitely try to be cognizant of that when I'm talking to people and I'm dealing with people so that they feel comfortable with me. And, hopefully we have